And we also know the importance of reporting standards that needs to be, standardized. And that is the reason why the whole Bathesda system came into existence, to help facilitate that standardization of reporting so that effective communication is maintained between surgeons, radiologists, pathologists, and any other healthcare providers. The Bathesda system of thyroid cytology was inspired by the cervical cytology, which was its predecessor in the 80s, in the 1988. And basically, the Bathesda system helps standardize information on thyroid neoplasia. So it helps facilitate easy sharing, collaborative research. It kind of almost gives a common language for pathologists to communicate thyroid cytology with the clinicians. The Bathesda system has 6 different categories, and we know all of that, but we also know that the category that we all are most concerned about in regards to or in regards to inter-observer variability and in its regards to the risk of malignancy and management are these 3 categories, which are the indeterminate categories in thyroid cytology, namely the AUS+, which is ATP of undetermined significance or follicular lesion of undetermined significance, follicular neoplasm or suspicious for follicular neoplasm, or the third category, which probably is probably the least inter-observer variability among these categories, is the suspicious for malignancy category. Cytologic criteria. So my talk spins around these 3 categories and basically emphasizes on the cytologic criteria and moving on to the molecular testing pieces. So I hope at the end of this talk, you'll be able to at least go through some basic criteria in these categories and how molecular testing has really helped. So let's start with the first category, which is the AUS+, which in Bathesda system is Bathesda 3 of 6. It is probably the most debated category in the Bathesda system. And the reason is it's also one of those categories which has the least inter-observer reproducibility. So the synonyms is AUS or plus. I've always been asked the question, which one is the better terminology to use? According to the Bathesda system, either AUS or plus is okay to use. It depends on the institution. It actually really is dictated by the institution. It doesn't really, what Bathesda advocates is use one or the other. Either use AUS or use plus. Do not use AUS in some cases or plus in some cases. Although I think in real practice, it really varies because I personally have used AUS in certain situations and plus in certain situations. In regards to which terminology is better between these two, I think AUS is far more versatile because AUS does not necessarily only encompass thyroid. When you call something atypia, which could be lymphoid, it could be metastases, or any atypical cells, you kind of give that broad category to it. Versus follicular lesion of undetermined significance kind of narrows it down to you're really talking about thyroid lesions here and nothing from outside or lymphoid. So that way AUS is probably versatile. The AUS is typically now in literature, what we're seeing is AUS is being resulted in approximately 3% to 18 to 20% of thyroid FNAs. And I think 20% is a pretty big number. Ideally, we should limit it to 7% to at best 10% for all thyroid FNAs. So I would be curious to know how your institution's AUS reporting rate is. In our institution in Montefiore, our reporting rate is on the lower end, about 7%. So we try to keep it like that. AUS should not be used indiscriminately, of course, because you don't want to use it just for most cases. I've had one of my mentors who told atypical is like the easiest result that anyone can report. You can never go wrong with atypical. But then the downside of doing that is we're just giving away our profession, because now if we start calling everything atypical, then, what's the role of cytology here? It's just everything atypical. So we really do not want to use this category indiscriminately, especially when these changes that we're talking atypical is very focal, or when we're looking at a sample that doesn't really have a lot of cells. So let's start with the case. Here is a 45-year-old female with a dominant 2.4 centimeter left thyroid nodule. And here is the diff quick smear of this nodule. And as you can see, it's a fairly limited cellularity, what we appreciate here. And you can see that there is a few microfollicles scattered in a background of largely blood. right? So, and there's not a lot of colloid. So this is the PAP as well. And you can see there's a lot of blood in the background obscuring some of these cells, but you could see relatively preserved microfollicles in this background. Some of these seem to have larger nuclei and some paleness to it, but overall it's very focal and very limited. So this was signed out as follicular lesion of undetermined significance, and a comment that scattered microfollicles in the background of abundant blood was made. And this was a surgical resection. As you can see, this is a lot of follicles. Many of them are microfollicular, no well-defined capsule here. And what we're seeing is these microfollicles pretty much represented some of these microfollicles in the cytology sample as well. As you can see, there is a lot of similarity. The surgical resection was signed out as nodular hyperplasia with a 2.8 centimeter dominant nodule. So this is an example of where a FLUS category should probably not be used, because as you can see from my original picture, the microfollicles were very limited, very few in a large sea of blood. So, in this instance, probably if it is neoplastic, it would have given cells or more microfollicles. The fact that there were very few microfollicles, they were so limited, they were so focal, this most likely was benign in cytology. But this is one of the cases where FLUS probably can be used because, this is most likely going to be benign, but we're not 100% sure whether this will be, malignant. So FLUS can be used. This is one of those cases where a cytopathologist can go either way, can go completely benign or can go on the FLUS route, but definitely nothing more than that. Cytologic criteria for AUS of FLUS includes one of the most prominent criteria is microfollicles, which is what we refer to in the Bathesda as architectural atypia. According to the Bathesda criteria, these microfollicles should be the prominent population in a scantily cellular sample. Because obviously, if the sample was very cellular and you found a lot of microfollicles, we're treading into the Bathesda 4 category or the follicular neoplasm category. So if the microfollicles are the prominent population, a scantily cellular sample, that's a good criteria to use the FLUS category. Or if the microfollicles are just more than what you normally want to see in a cellular sample, then you can use this category. This category is very helpful when you have a lot of air drying artifacts or clotting or blood artifacts. And the reason is because the nuclear details are very hard to see in some of these artifacts. And you don't want to go over and just call this benign or call it malignant when the sample is just suboptimal for rendering such a definitive diagnosis. So in this instance, the atypical category is a very good category to use. Obviously, if there is cytologic atypia, one needs to use this category because, sometimes you may only find focal features in a largely, limited sample, cellular sample, and just those focal features suggestive of PTC in what other setting can appear, in a setting that otherwise looks benign, is a good, criteria for using the AUS category, for sure. This is, again, one more area where you can throw in the AUS category because, cyst lining cells can be troublesome. Like here, as you can see, in some of these cyst lining cells can show even inclusions. And this has been reported, by Bill Faquin in one of his papers, where he shows that these cyst lining cells actually can have nuclear features that almost mimic papillary thyroid carcinoma, including the inclusions, that they are just reactive cyst lining cells. And the inclusions here are just nothing but degenerative changes. So these atypical cyst lining cells can be problematic, and atypia, and this can be a good category where atypical AUS can be used. One other category, which I think a lot of people tend to over-abuse the AUS category, is the Hurdle cell category. Somehow it looks like Hurdle cells and microfollicles are just scary. So, I've seen a lot in my personal experience where seeing either microfollicles or AUS, one just, gets alarmed and just puts it in the atypical category. So when do we use Hurdle cells for an AUS? So basically, similar to microfollicles, when the aspirate has predominantly Hurdle cells, but it's a sparsely cellular aspirate and scant colloid, then it's probably reasonable to use the AUS category. Or if there is an exclusive population of Hürthle cells, almost like monotonous, in a moderately cellular aspirate, although the clinical setting is benign and everything, you can probably raise a little red flag of this being an atypical category. But if you're just seeing few focal areas of Hürthle cells, just few Hürthle cells, but largely looks very benign, other benign appearing follicles, but few Hürthle cells here and there, it is a metaplastic change, and you don't want to really overcall that to be an atypical category. Also, atypical category can be used for any follicular cells that shows nuclear enlargement, prominent nucleoli in patients with history of some sort of treatment. And you can also use this category for atypical lymphoid infiltrate or atypia that is not otherwise categorized. All right. So as a final thought for the AUS category, I would like to point out that use AUS of FLUS when the cytology is not convincingly benign. This is how I try to do it. When I look at a slide and I am not 100% sure that I cannot go to bed without, being convinced that this was benign, then I use this AUS category. It's literally, sometimes, it's that intuition. It's like, something's wrong with it. It's not convincingly benign. That means the degree of cytologic or architectural atypia is not sufficient enough to categorize as to bump it up higher as follicular neoplasm or suspicious, but you're not able to bump it up lower to benign. So that is when you really use this AUS category. Always make sure to use this category, or this is where I like people to liberally use this category, is when there are confounding factors. Like compromised samples, such as very low cellularity or obscuring blood and poor fixation. You don't want to really pull your muscle and name that as either benign or something worse, because this is exactly where you want to use this category. So this was a study, it's very recent, it's probably one of the most recent papers in 2021 that talks about the final cytologic diagnosis in nodules with AUS FLUS on initial FNA that underwent repeat FNA. So as you can see, among 285 cases here, I think this was a study from Spain, and these authors show that a large part of these AUS FLUS on repeat FNA tended to be benign, and only very few on only very few were repeat AUS FLUS, about 21%. But a large share of it is benign. So that is actually the real reality with AUS FLUS. A majority of AUS FLUS still tends to be benign, but then there is always this worrisome that there is a little bit of a minimal amount of them that goes to being suspicious or even malignant. So that is what we're trying to solve. And as you can see, a fair share of them still remain to be AUS FLUS, and this is exactly the kind of cases that need to go for molecular testing. So some important facts: AUS, a single diagnosis of AUS carries a low risk. As you can see, the repeat tends to be more benign. So therefore, avoid overuse of this category. Keep it limited to at least 7 to 10%, because you don't want unnecessary management or aggressive management on these cases, because a lot of them tend to be benign. So moving on to follicular neoplasm, suspicious for follicular neoplasm category, which is the Bathesda 4. This category is specifically for lesions that are follicular. So follicular pattern lesions. And what are those? Those are hyperplastic or adenomatoid nodules, follicular adenomas, and that we only know based on the well-defined thick capsule, follicular carcinomas, which tend to be malignant, and either show capsular or vascular invasion. And now we tend to use follicular neoplasm in this category of follicular variants of PTC as well, because they tend to be a lot follicular patterned, but then show cytologic features of PTC. So sometimes it can be, these cases of PTC can be lumped into the follicular pattern lesions. Obviously, we know the cytology has no way to differentiate between follicular adenoma and carcinoma. Therefore, the goal of this category, that is a Bathesda 4, was really put in place to identify potential follicular carcinomas. But now with growing NIFP in many of now growing awareness of NIFP in cytology, we're now tending to use follicular or Bathesda 4 for even those cases that we potentially think would be NIFP cases. There is this category, using this category, there's a high likelihood of neoplasm in this category, unlike AUS where there's a high likelihood of benign. But then the malignancy rate in this category is very low. So let's start with a case. For this category, I actually have a few more cases because I think, it's very nice to show pictures and kind of make some few points on this particular challenging category. So 65-year-old female with a right upper to mid pole, 1.5 cm nodule, mostly solid with cystic areas. And you can see this is the nodule here, a picture of this nodule showing predominantly oncocytic cells or Hürthle cells. Again, the Bathesda system wants you to use the term oncocytic rather than Hürthle. So we will refer to this as oncocytic cells. Oncocytic cytoplasm, fairly round nuclei, and slightly enlarged compared to that of the red blood cells. You can see the enlargement of this nucleus. And there is a nice vascularity running through these, large clusters. And this is the pap smear, again, showing a lot of cellularity. And for a follicular neoplasm category, cellularity is an absolute must. If you don't see an aspirate that's cellular, please don't even try going towards that category. Lack of cellularity is definitely should sway you away from using this category. So cellularity and scant or absent colloid are two features that I use to really bump it up to follicular neoplasm or something beyond that. So here you can see these are again oncocytic cells, nice granular cytoplasm, enlarged nuclei, and really not able to appreciate a lot of other nuclear features here. This is again another area of PAP where you can see the nuclei a little bit paler. There's probably a groove here and a little bit angulation, but some of them are rounder. There's a little bit of overlap. So there's a hodgepodge of cytologic features here in a largely oncocytic cell, largely oncocytic type cells. So this was signed out as suspicious for a follicular neoplasm, Hürthle cell type. And this was the nodule that was removed. And as you can see, it has a nicely, almost well circumscribed except for here. And this was that nodule, low magnification of that nodule. So on higher magnification, you can see that these nuclei closely resemble to the nuclei that we saw on our cytology aspirate. And these are more pale, and there's a groove. You can see there's a groove here. So there's some overlap and so on. So these features led to the diagnosis of this being a papillary thyroid carcinoma, oncocytic variant, and no lymphovascular invasion is identified. So the criteria for follicular neoplasm, as I obviously mentioned, the aspirate should be cellular, cellular, cellular. I can't emphasize more on the cellularity that is much needed for this particular category. The cellularity should be comprised of follicular cells with what we call as altered architecture, wherein there's microfollicles and with cell crowding or overlapping. And you absolutely have to have scant to absent colloid in this category. And also note, because of the prevalence of the follicular variant of PTCs, especially NIFP, follicular pattern cases with mild nuclear changes, like we saw in our case, can be classified as follicular neoplasm, so long as true papillae and internuclear inclusions are absent. So what if true papillae and internuclear inclusions are present? They automatically get bumped up to suspicious, or even if you see a lot more, the malignant category. All right? So this is the cellular aspirate that I'm referring to. See the sea of cellularity that we're seeing should be, this is what we call as neoplastic cellularity. So this is a neoplasm. And altered architecture is what we're talking about here, which is pretty much the hallmark of follicular neoplasm category, cellular aspirate with altered architecture. So what do I mean by altered architecture? It means you have crowded and overlapping cell groups that are mostly as microfollicles. So you can appreciate the crowding and overlapping in some of these cell groups. The Hürthle cell or oncocytic type in this category, which is suspicious for follicular neoplasm or follicular neoplasm oncocytic type, refers to mostly the identification of Hürthle cell neoplasms or Hürthle cell carcinoma. That's a whole goal of that category. But many times we can see that it's being overabused, and probably should not be, because Hürthle cells, the most common aspirates we see Hürthle cells tend to be reactive or hyperplastic or benign. That's where we're seeing more Hürthle cells. We're not seeing Hürthle cells are very few of these Hürthle cells tend to become neoplastic. So remember that when you try to call something in the neoplasm of a Hürthle cell type, most of the time they tend to be in the reactive, metaplastic, or hyperplastic conditions. Also, it's unfortunate with the Hürthle cell category because there's a lot of molecular changes that we can appreciate, like how we do in PTCs or medullary thyroid carcinoma. And so the only distinct molecular characteristic that we're seeing is the PAX8 gamma gene rearrangement that potentially can separate follicular carcinoma, which tends to have more of these rearrangements from Hürthle cell carcinoma, because Hürthle cells really don't have a lot of signature changes yet. If you're going to use this category, suspicious for follicular neoplasm Hürthle cell type, you can use, if you want to put this in a Bathesda 4 category, let me rephrase that. If you want to use the Bathesda 4 category for this oncocytic type, try to use suspicious rather than calling it outright follicular neoplasm, because suspicious for follicular neoplasm is probably a slightly preferred terminology because of the amount of these tending to be non-neoplastic, because a good chunk of these tend to be non-neoplastic. So use suspicious for follicular neoplasm over follicular neoplasm. I hope this is clear. So moving on to the next case, we have a 35-year-old female with a left mid-thyroid nodule, predominantly solid, isoechoic, no internal calcifications, and showing peripheral and internal vascularity. So it's a 3.4 centimeter nodule. And as you can see here, there is quite a bit of cellularity here. And as soon as I see the cellularity, I'm in the neoplastic category automatically. Now I try to look for any features here that can bump it up to suspicious, or it can stay in neoplastic in Bathesda 4. And as you can see, there is still some crowding, some kind of overlap. There is a little bit of paleness, a lot of microfollicles and blood. And this is a nice, ton of microfollicles here and overlapping, some paleness. So this is a good, use for Bathesda 4, suspicious for follicular neoplasm. And I use the term cannot rule out follicular variant of papillary thyroid carcinoma only because of the presence of those paleness to those nuclei. So this did come out, and we can see it was a 3.3 centimeters, a little bit above 3 centimeter nodule. And you can see it has a thick capsule, sort of, but something seems to be going beyond this capsule. There's a little bit of encroaching. And as you can see, the tumor is slightly pushing itself out of this capsule. Cytology-wise, the cells are pale, very much like papillary features, pale, overlap, small nucleoli peripherally placed, all features that we would consider papillary for. And so this was signed out as papillary thyroid carcinoma encapsulated follicular variant. And there was focal capsular invasion that we saw. And also there was a single focus of vascular invasion. So this is another case of a 34-year-old female with a dominant 4.4 cm right thyroid nodule. And these slides were submitted from an outside institution with a referring diagnosis of Bathesda 5 category, suspicious for carcinoma. And this is our aspirate, again, fairly cellular. So once I see this amount of cellularity, I'm going to put it in the neoplastic category. Some may argue, is this colloid or is this extracellular, metachromatic material? I think that is what it is because it has a really nice defined shape to it. So I don't think this is all colloid. It's just some extracellular material. Cytology-wise, these cells, again, do have these grooves, paleness to the chromatin, but I did not appreciate any signs of intranuclear inclusions or so forth. There is a central hyalinized kind of stromal material surrounding which these cells were dispersed or aggregated. And you can see the background also has a ton of cellularity. This is the thin prep of this case. Again, you can see the thin prep really condenses cellular material tightly, so you're not able to appreciate that big flowing metachromatic material. Rather, it's all just lumped into right in the center. But you do appreciate the nuclear features, which are pale. So this was signed out as follicular neoplasm. Differential diagnosis did include a papillary thyroid carcinoma because we're always wanting to rule that out because it is the malignancy that we want to rule out. But then we also introduced this term hyalinizing trabecular adenoma to the report only because some of these features like metachromatic stroma, the extracellular material, the paleness assigned to the chromatin. All of these kind of contributed towards that working diagnosis. And the nodule was resected, and as you can see, there are these type of cells here, again, very angulated looking, groove, almost looking like papillary, which is very similar to what we saw in our smear. This was this nodule turned out to be a hyalonizing trabecular tumor. And we thought that was an interesting use for follicular Bathesda 4 category. So always remember, use the Bathesda 4 category when you have very high cellularity. I mean, I can't emphasize that more. Obviously, if you see the other nuclear architectural atypia, it definitely is an added bonus. Especially if you see follicular pattern cases with mild nuclear changes of PTC, that's a good category where you can use the follicular neoplasm category for that. Let's quickly move on to Bathesda 5 because this is not a very hard category to conquer. This category came into existence because we needed a category where we needed to preserve the high positive predictive value of the malignant category, right? So we didn't want to have a category from follicular neoplasm all the way to malignant, then it'll compromise the sensitivity, which is why the Bathesda 5 category was introduced. So in any cases where, the way I use Bathesda 5 is when I see an aspirate that reminds me of papillary, but there's this one thing that I'm not absolute. I do not find inclusions. If I don't find inclusions, I don't put it to malignant category. I bump it down to suspicious. For me, inclusions need to be there in addition to all the other nuclear features of PTC to call it malignant. So, and again, that is subjective. This is how I practice, and I hope you find this helpful. So let's start with the case, 40-year-old female with a 4.2 cm dominant nodule in the left mid-lower pole with internal vascularity. And this is the nodule that we're considering. So it's there's a lot of almost like very microfollicular look. There's this huge chunk, and you can see there's a lot of cellularity in the background. That is definitely obscured by blood, but it is there. So these are very, very tightly aggregated. Kind of, some of them have a little bit of a syncytial appearance. Many of them do tend to look very microfollicular. And this is the thin prep that shows the nice cluster of this. The nuclear features are not very suspicious for a PTC. Obviously, they're very dark and round-looking nuclei, but the fact that these are so many of them clustered was concerning. And what was most concerning was this is cell block, which showed mitosis that was scattered throughout the cell block. And you can see these kind of aggregated with the central lumen, very follicular arrangement here, and cell nuclei that doesn't really fit for a papillary thyrocarcinoma. So we were really concerned about a poorly differentiated thyrocarcinoma here. So we did bump it up to a suspicious for malignancy category. And then the surgical resection was done. As you can see, it really matches our cell block cytology and showing nice arrangement of these almost acinar structures here with very round, dark nuclei and small nucleoli. So this was a poorly differentiated thyroid carcinoma. It's a pretty big tumor, about 7 centimeters. So with this one, that was the categories. Now we're going to move into the Bathesda system. And I just want to emphasize on a few challenges in the current Bathesda system, which still haven't been resolved. But I think moving forward, we'll have more iterations to that. So one of the bigger challenges now is the NIFP, right? Because it is a terminology that was introduced more recently in 2016. And now we have included the NIFP in our Bathesda and have given a potential risk of malignancy here. This is that big landmark paper that talked about the first introduced the terminology of NIFP for encapsulated follicular variants of papillary thyroid carcinoma. It still proves to be an ongoing challenge in the cytology world. Why? Because, really we don't know what the prognosis of NIFP is. So far, we consider it to be very more of a low risk, good prognosis, but still we really don't know what the prognostic is. We need to have more long-term studies. But more importantly, NIFP has a great degree of overlap cytologically with PTC, especially the invasive follicular variant of PTC. So, by overcalling it, we could be aggressive and have a larger surgery for the patient, but by undercalling it, we may miss a malignancy. So that is why there is this. This has become a challenge. And obviously, we are not able to use cytologic features alone to make the distinction. So The best way to address NIFP so far is anytime you look at a follicular pattern tumor, and if you're thinking it's a follicular variant of PTC, you want to downgrade it from malignant to suspicious or even follicular neoplasm category, only because the management will not be as aggressive. So they can only do a lobectomy and not a total. And that is very helpful for the patient. So in an explanatory note, you can suggest the possibility of a NIFP in a follicular pattern lesion with nuclear features of PTC. That will warn the clinician or the surgeon that please don't remove the entire thyroid. This could be one of those that really needs only a focal resection. NIFP, therefore, inclusion of NIFP in the Bathesda category has altered the risk of malignancy in the various categories. So some of the recommendations by the Bathesda is if you see cases with borderline nuclear atypia associated with PTC, it's borderline nuclear atypia associated with PTC, and you're thinking of follicular variant of PTC, try to include it in follicular neoplasm or suspicious for conservative approach. You don't want to go all the way to malignant, especially if it's only borderline nuclear atypia. And, if you're going to do that, you can always suggest the possibility of NIFP in a comment. Right? And that way they can use molecular testing in these nodules and then make a definitive management rather than going aggressively. And also try not to, classify papillary thyroid carcinomas of what variant it is. Just limit the way papillary PTC to classical type. And if you're really thinking about a NIFP, you can have an optional note suggesting NIFP. So don't go looking for variants in PTC in cytology. So now with that, let's move on to molecular testing, which is going to be the last portion of our talk. Molecular testing has become the standard of care in thyroid nodules, obviously, because we have the large AUS plus category and the follicular neoplasm category. It has really been helpful, at least in our experience in the United States. We've found it incredibly helpful to further refine AUS and a follicular neoplasm, and really has helped spare a lot of aggressive management here. So I'm not sure how prevalent it is in India, but I'm hoping that, there are larger centers have that because it really adds value to the Bathesda 3 and 4, and therefore to the overall healthcare for the patient. It started because BRAF V600E became the most prevalent mutation in PTC with a specificity close to malignancy. So then that kind of garnered interest in trying to look for mutations of other sorts in thyroid nodules and adding more genes to improve the sensitivity of the panel. So now the three major players in this area are Verisite, or the Afirma gene expression classifier, Thygenex, or the thyroid oncogene panel from Interpace, and ThyroSeq, which is gaining ground a lot in these times. So the basic fundamental idea why these three molecular tests even are existing is for these two reasons. One, to better predict benign nodules, right? Which nodules do not need surgery? That is the fundamental reason why we need these testing. We don't want to be aggressive on those nodules. Number two, now what additional information we're getting is that these tests are able to distinguish high-risk carcinoma versus low-risk. So that means it's lobectomy versus a total. And lymph node dissection. So let's go to the first molecular test on this panel, which is the Afirma gene sequencing classifier, which is from Verisite. It is one of the updated next generation sequencing based RNA sequencing platform, and it uses two dedicated passes that has to be expressed into a proprietary preservative that only Verisite has a patent for. The more recent, that is a gene sequencing classifier from Afirma, has expanded from 142 to now 10,196 genes and includes 12 independent classifiers and about 1,000 and odd core genes. Additionally, also, they're able to have classifiers to identify parathyroid, to identify medullaries, and also red PTC fusions. And they're also able to give a little bit more detail in Hürthle cells for Hürthle cell lesions by providing a Hürthle cell index and Hürthle cell neoplasm index, which helps you either tilt in favor of neoplasm or tilt in favor of benign. That was one of the fundamental flaws that people had with Afirma, is that it was not helpful with Hürthle cell lesions. But the more recent Afirma testing does offer some solace to that. And I just want to put it out there. I'm not advocating any particular molecular test here. I'm just stating what are the pros, cons, and this is up to each institution to identify the molecular test that best suits them. All right, the sensitivity of Afirma has been unchanged since the testing began. It's been 91%, but what's happened is specificity has gone slightly more. It used to be in the upper 40s. Now it's really gone to the 68. So what it says is that the Afirma now with the more refined testing, has been having a better benign call rate that seems significantly higher, and they're able to better classify their Hürthle cell nodules. It is one of those rule-out tests. It has a very high negative predictive value. So when Afirma result comes up as like 5, when an Afirma test is benign, that means you know that the nodule is most likely going to be benign as well, because only 5 to 6% of those nodules tend to be malignant. So this is the Afirma. Again, you can see it can be expressed. So when the patient undergoes a thyroidectomy, 2 dedicated passes are expressed to Afirma for the Afirma classifier, and the remaining passes go for cytology, here thin preparation. And as you can see, the Afirma runs its own panel, and it can classify a medullary thyroid carcinoma separately. And if it's positive, of course, it's medullary. If it's negative, then it goes for its 142 gene expression microarray, and it can spew either a suspicious or a benign result based on the genetic signature. And on all suspicious cases, it goes an additional step for BRAF to identify whether there is BRAF positivity or not. So obviously, BRAF positivity confers a high risk. So thyroid oncogene panel is slightly different in that it is also a targeted next-gen sequencing-based platform that identifies more than 100 genetic alterations across 10 genes and 6 fusions in thyroid malignancies. But in addition to that, it uses a microRNA classifier to further enhance the sensitivity and risk stratification. Unlike Afirma, we just need one dedicated FNA pass. And again, it can be collected in a preservative such as RNA retain. And, let's move on to the next slide here. You can see that one dedicated pass is collected in the preservative. The remainder goes for cytology. And a targeted panel is run for detecting fusions and mutations. And as you can see, these are all the various fusions and mutations that can be identified by ThyGenX. The top 3 are the ones, if positive, are conferred a high risk, and then the patient undergoes a more aggressive surgery or treatment. If any of the others are positive, if these are negative, then it's tested. Then if it's positive for any of these others, then it still goes for a microRNA classifier, irrespective whether it's positive or negative for the others. And then based on the positivity or negativity here, it either gets a high risk or a low risk report. And so this is just the other steps that I just highlighted. As you can see, the sensitivity of this particular testing is pretty good. It's about close to 90%. Specificity is 85%. Negative predictive value is as close as Afirma, which is 94%, and positive predictive value is slightly higher at 74%. So ThyroSeq is the latest player, and it's been very promising, and it's been largely used here. In our center at Montefiore, we use ThyroSeq as well. So ThyroSeq is one of those expanded NGS panels that analyzes over 112 genes, provides information on over 12,000 mutation hotspots and over 120 fusion types. It's probably got the best sensitivity so far, but the literature is limited. Sensitivity is close to 94%. The specificity is probably far higher at 82%. Negative predictive value is also higher at 97% and slightly higher positive predictive value at 66%. So ThyroSeq, again, you take the sample, you express into ThyroSeq preservative, and the remainder of sample goes into cytology, and a targeted panel is performed, and then ultimately the results are spewed as high risk or low risk. ThyroSeq has been especially promising in the area of Hürthle cell lesions, where, as you can see from this particular paper back in 2018, You can see the ThyroSeq was able to completely identify all those Hürthle cell non-neoplastic lesions. So if it was negative, it was rest assured they were non-neoplastic or benign. And it was able to identify most of the malignancies as well here. The only area where I think it's not able to prove very well is in the Hürthle cell adenomas, the benign neoplasms, which probably is where the test goes 50-50. But the good news is it's able to rule out all those non-neoplastic lesions and identify all those most of those positive lesions. So how do we use this molecular testing? What's the best way to use it? I kind of put this chart out because then you can choose which testing works for you. And so, these are the various areas where each testing performs better than the other, or all the tests perform pretty similarly. Thank you very much. With this, I will take leave. And if there's any questions, I will be. My information is there on the website, and I'm sure the coordinators or the moderators have that information, and you can reach out to them with any questions. And I look forward to seeing you all in the near future. Thank you. Bye.